tachycardia due to vasoconstriction, right? So that's the reason why by having hypovolemia, there is decreased preload, there is decreased cardiac output and index and stroke volume, and the increased heart rate due to vasoconstriction will give you increased systemic vascular resistance, all right? Now, remember that all the shocks will have tissue hyperperfusion, right? And that is also reflected in central venous catheter when you measure the saturation of venous oxygenation, which is SVO2, all right? So the amount of oxygen present in the tissue or the tissue extraction, don't get confused, is elevated, but the amount of oxygen present at the level of the tissue is decreased. So that means that the SVO2 is decreased, okay? In all the shocks. So we already said that there's no accuracy on the actual blood pressure. So again, what do you have in hypovolemic shock, including hemorrhagic? So again, you have hypovolemia, therefore hypotension. You have tachycardia due to sympathetic response that is not affected, increased heart rate. There is narrow pulse pressure, right? Because even though the patient has hypotension, there is a very, very close reading on systolic and diastolic difference. You know that there is shunting away of volume from the GI tract and kidneys to the main organs, and you know that the preload is decreased, cardiac output and stroke volume is decreased, and therefore continues the vicious cycle of hypotension. Okay? So we already know about lactic acid, so I'm not going to repeat myself. In the initial stages of shock, of course, the metabolic acidosis is less compared to the later stages of shock. So even though you might have lactic acid production or elevated, maybe the base deficit is still within normal limits until advanced stages. So remember that the base deficit is -+2, okay? So might be still normal even though the patient is in shock, okay? Now, once the hypotension and hypovolemia continues, and you have, for example, as it says here, you lose a third of the blood volume is when all the hemodynamics continues to deteriorate, okay? So, as you can see, as the process advances, of course, there's lower blood pressure. That's when you have to decide to put the patient on vasopressor support. When it's not responding to the first treatment, volume resuscitation for hypovolemia, inotropic support in cardiogenic shock, epinephrine, for example, for anaphylactic shock, atropine, for example, in neurogenic shock, etc. Okay? So if it's not improving, then what's going to happen is that the process continues and the base deficit is going to be even worse, like more, like greater than -2, okay? And of course the acidemia worsens as well. So during resuscitation, again, what we actually expect is to bring the whole etiology of shock, either hypovolemic, septic, etc., back to the normal parameters, right? To avoid actually organ injury. So we have gone through all this already, so I'm not going to repeat myself, right? Like neutrophil generation and all that, because we're wasting time. Okay? So, as I'm not going to ask you the classification, but it makes sense that shock, not only hemorrhagic, is really depending on the stage that you catch your patient, right? You could have a mild hemorrhage, right? Like maybe 1 or 2 episodes of hemoptysis. And even though the patient is hypovolemic and hypotensive, the base deficit, for example, is not affected. Maybe at that time, blood resuscitation, giving pipette cells and bringing the patient to the OR is what actually suffixes the problem, doing bronchoscopy and catheterizing, etc. There's no severe, as I told you, maybe when you do an APG, there's no metabolic acidosis yet. There's no shifting of the base excess. When it goes into severe hyperperfusion, you actually start seeing already the shifting of the base excess and the worsening of the metabolic acidosis. What do you see in any type of hemorrhagic shock? For example, you have an or hypovolemic shock, you see the patient that is cool, clammy, sweaty, you see the ill appearing status of the patient. Of course, you're gonna see the hypotension that if it's a mild state, it might go back to normal, the hemodynamics after fluid resuscitation, but otherwise the patient might be going into vasopressor support, right? Hypotension and tachycardia, we already mentioned that. Now, remember that if the patient is in a state, mild up to severe of metabolic acidosis, we compensate with respiratory alkalosis, which is hyperventilation state. So it is normal that you would see your patient in tachypnea, right? And respiratory alkalosis, that's expected. Unless the patient is tired already of breathing fast, and that's when you start retaining CO2. Again, lactic acid will be increased, even more than 4 in severe stages of hypovolemic shock, and of course you're gonna see a higher deficit more and more depending on the stage, okay? Urine output, of course, the patient might go from oliguria to anuria, and if the hypotension continues, then of course there's tissue necrosis and the prognosis is actually very poor. Treatment, how will you treat any type of hypovolemic shock? Fluids, even if it's hemorrhagic, okay? You have a protocol of emergency transfusion that you give the patient the most available blood. Hopefully you have O negative, right? That you can give it to anybody without tapping a cross. But if it's, if you can wait, resuscitate the patient with lactated ringer or normal saline, right? Crystalloids. Meanwhile, tapping and crossing the patient and transfuse to avoid any type of rejection, okay? So this is basically the protocol for children, but we already know, right, that it's 30 mL per kilo IV fluid resuscitation, yes.
So what do you do in case that the patient refuses the blood transfusion, like the witness, the Jehovah Witness?
No, but they have like
It really depends, because some patients refuse everything, blood and byproducts.
Exactly.
And some patients accept byproducts like albumin, heparin, etc. And you can refuse that. Otherwise, you have no other choice that only give crystalloids.
Okay.
And hope for the best that you're able to find the source of bleeding and fix it. Okay? So, as I said, try to look for the source, and if it's necessary, bring the patient to the OR to fix, you know, if it's an artery bleeding or, for example, trauma related or necrotic bowel that the patient is bleeding from there, or recent surgery. Actually, you know that we had a patient that was in the ICU. The patient just had ELAP, cholecystectomy. Okay? Well, what complications do you expect from that? Like, everybody almost leaves the next day home. Well, I think I actually gave the history.
No.
Well, the patient left the ELAP cholecystectomy the next day, actually, and she was feeling well. And then suddenly she became vomiting and having distended abdomen. And so besides many complications at the end, which, remember I talked to you about this case I think last week?
Yeah.
Well, she actually ended up worse because one of the cystic artery was leaking.
Yeah.
Okay? You know the cystic, right? It's a cystic duct. Okay? There's actually a duct that communicates to duodenum and pancreas. So that artery of the cystic duct was actually dissected, and she was like, thank God that it was like triple bleeding. Okay? But she was improving. I don't remember what complication was before, and then she kept, you know, like all hypotensive, and the abdomen was getting worse and worse, and they took her back to surgery, and the hemoglobin dropping, and the reason what she had was that the cystic artery was nicked, and she was drinking blood from there, okay? So either, again, bring the patient to the OR to try to either do exploratory laparotomy, if it's really, in this case, in the abdomen, and try to find the source and fix it. Meanwhile, again, volume, blood, products. In the case, for example, of cardiogenic shock, you know that inotropic support is the best. Sometimes, as I said, if you have a patient, listen to me, if you have a patient with past medical history of CHF, systolic heart failure, and patient comes in bleeding, this patient has hypovolemic shock from bleeding, right? But it doesn't matter how much fluid you will give to this patient, or exactly, packed red blood cells you might give to this patient, the heart is unable to pump properly. So sometimes putting that patient on inotropic support also will help and prevent pulmonary edema. Okay, so for example, what type of hemodynamics, vital signs wise you're expecting on a patient with hypovolemic shock? Remember, hypotension, tachycardia, right? And the shunting away of the fluids to the main organs might give you renal hyperperfusion and oliguria. So in sepsis, there's also stages of sepsis, right? You have systemic inflammatory response syndrome, sepsis, severe sepsis, and septic shock. So every time we have a patient, which not all the time is accurate, we receive a patient with temperature of 38, so hyperthermic or hypothermic, patient with a heart rate greater than 90, which we actually haven't updated up to 100, right? So tachycardic, tachypnic, in respiratory alkalosis, that means hyperventilation, with a WBC of more than 12,000 or leukopenic, we bring the red flag of possible sepsis, right? And we call a code, and we put the patient, again, in cultures, broad spectrum antibiotic, and we give fluids to this patient. Sometimes it's just a matter of maybe, I don't know, for example, patient might went to an elective procedure yesterday, and might be the reason why the WBC went high, not necessarily there's an infectious process, right? And just the fact that the patient might have pain from the procedure might bring the heart rate high and respiratory rate high, and they call sepsis. So yes, it's a screening process that we catch a lot of patients and prevent infection and therefore mortality, but we are actually going far and beyond and treating everybody the same. And when the patients, basically the assessment is not proper. That's what I'm trying to say, okay? So before sepsis, you treat everybody the same instead of like analyzing why, okay? So let me come here so you could see the whole spectrum. For example, from SIRS, which are all the parameters that we already went through, okay? So the classification of sepsis is systemic inflammatory response syndrome, to sepsis, which you actually are able to see the infectious process, right? To having already an organ damage, which could only include oliguria, right? Isn't that? Or bionecrotic elevation, isn't that an organ damage? Mm-hmm. Up to the point of hypotensive shock. So this hypotension doesn't mean hypotension only, because you can be hypotensive in sepsis and severe sepsis as well, but this patient is not improving after the fluid resuscitation, and it's already on vasopressor support. Okay? Looking at it, let me come here and I can go back. Looking at this in another way, for example, again, you have your systemic inflammatory response syndrome, sepsis is actually having two of this, right? Plus, again, a confirmed, for example, blood culture, or for example, if you did a lumbar puncture and you see already the turbid color of the CSF, or if the patient, for example, thinking about meningitis, has already Kernicka-Brusinski, or the actual rash of meningococcemia, or if you have pyuria, like turbid urine and dysuria. So having suspected due to clinical signs and symptoms, or an actual positive blood cultures or urine culture, etc., is the sepsis state. Severe sepsis, of course, you have the patient in hypotension as well, with any sign of organ damage, as I explained. Of course, the lactic acid will be elevated, but here might be, for example, 2, but increases as you worsen this stage. And of course, in this particular patient, yes, they do have hypotension as well, and as well lactic acid elevated, but the patient is not responding to fluid resuscitation and requires vasopressor support. Here it's basically saying more or less the same. Now, which type of antibiotic we already went through, right? Broad spectrum antibiotic. We have to start broad and then narrow down based on blood culture results. Here it's not only positive, okay? So basically remember that the most common source of an infectious process, if you're not immunocompromised, if you're not coming from a nursing home, if you're not a prisoner, if you're not have traveled recently or have been hospitalized recently, then yes, it's gram-positive. Otherwise, you would have to think more broader, like including gram-negative and anaerobes, right? So that's the reason why we included beta-lactam, which could be your third or fourth generation cephalosporin. That is, again, Yosefi, or Maxipine, Cefepime, which is fourth generation, right? If you would like to choose penicillin, remember combination penicillin, right? So chazotocin is one, and always try to add vancomycin to cover what? MRSA, right? And the reason why you include third or fourth generation or combination penicillin is to cover Pseudomonas, right? Now, you can also add, for example, an aminoglycoside, but remember, in a patient with shock already with, for example, pre-renal failure, giving an aminoglycoside, you can put the patient into more nephrotoxicity, okay? So continuing with sepsis, this is again pathophysiology. If you remember, there is the main trigger, either an endotoxin or an exotoxin, depending if it's gram-positive or gram-negative bacteria, or either a viral disorder as well. What happens is that, again, there's inflammatory cascade activation, right? There's cytokines release, and you know that the cytokines will give you what? Vasodilation, capillary permeability, diapetes, and that's right here. And the actual capillary permeability will give you edema at any area, central, pulmonary edema, cerebral edema, or peripheral, like lower extremity edema, and jugular vein distension. Remember that tumor necrosis factor is the one that triggers the febrile response. You remember that? And the catabolic state, the cachexia elevation, when the sepsis is prolonged. Okay, of course you can have leukocytosis. Remember that as well. In the initial stages of sepsis, you have leukocytosis, right? But when there's an overwhelming sepsis, there's a high consumption of leukocytes and neutrophils, and instead you have leukopenia. So leukopenia in a patient that came in septic is actually a poor prognostic factor, okay? So this vasodilatory state of the cytokine release, remember, will give you a non-cardiogenic pulmonary edema initially. Patients would have a dull respiratory distress syndrome as complication of any type of shock, but of course mostly sepsis related, okay? That's initial stages. Non-cardiogenic pulmonary edema, ARDS. Later on, late stages of sepsis and septic shock, what's gonna happen? What did I say? Any shock gives you what? Metabolic acidosis. Any shock and metabolic acidosis is a negative inotrope, right? In addition to that, any shock can give you entrapment of calcium into the sarcomera, producing coronary ischemia and coronary syndromes and heart failure. So initial stages of any shock can give you non-cardiogenic pulmonary edema, ARDS, that is treated with steroids. But later on, you have a depression of ejection fraction, and the patients actually accumulate more fluids due to cardiogenic pulmonary causes. And that's when you start doing basics. In reality, we don't know which stage we are in, and that's the reason why we try. We try steroids, we try Lasix, okay? But unfortunately, in an exam, ARDS does not require Lasix, okay? It's an inflammatory response, an overwhelming inflammatory response, and that's the reason you have to depress the immune system with steroids, okay? So, of course, patients going into the RDS, you know that that's the classification of type 1 respiratory failure, which is hypoxemic respiratory failure. And you know that this area right here, what happens is that first again, deviation of blood supply from the kidneys, from the GI tract to the main organ, so producing ileus paralyticus up to the point of mesenteric ischemia, producing oliguria, pre-renal renal failure up to the point of acute tubular necrosis and CKD, right? In addition to that, you know that having the liver inside this plaque circulation, which is your belly, the liver goes into hyperperfusion as well and ischemia. So every single patient that comes to the ICU in shock of whatever etiology is going to have what's also called liver shock. You're going to see a high spike of liver function test, but you don't do anything with it. Just leave it alone. And you will see as you start treating the shock, the etiology of the shock, the liver enzymes will start getting corrected, okay? Now, don't get me wrong, if you see the patient's getting better and suddenly the liver enzymes getting worse, that's contradicting, right? Remember that we have something that's called acalculous cholecystitis that is present in patients. That is present in patients with critical illness in a prolonged state of hypoperfusion, and that patient you would have to bring him to the OR to either drain out the gallbladder by cholecystostomy or taking it out. Okay? So, but in the initial stages of any shock, any acutely ill patient, you would see liver enzymes spiking, but they must correspond as well with this critical stage of the patient. So, patients critically ill at the beginning, liver enzymes high. Patients getting better, liver enzymes are getting better. If it's backwards, you have to think about possible I have acalculous cholecystitis, right? So what else? Remember, I told you, cascade of events, inflammatory cascade, but also coagulation cascade gets activated, and that's the reason not only the patients have high risk for thrombosis, PEs, strokes, MIs, DVTs, but even if it becomes a vicious cycle up to the point of descending into a vascular coagulation. Okay? So, again, in septic shock, remember that the hypovolemia state of septic shock is not because you're dehydrated. Listen, it's not because you're actually dehydrated because you're vomiting or having diarrhea or whatever. It's because you have what's called redistribution of fluid. There's so much vasodilation and so much leakage outside to the third space that the vascular space is depleted, okay? So it's called redistribution of fluids, okay? So that's why it's called relative hypovolemia, okay? Now, if you have in addition to, imagine that you have, I don't know, diverticulitis, right? Appendicitis, cholecystitis. That's the infectious process itself, that it could produce a relative hypovolemia due to sepsis. But if you now start throwing up, right? that's an additional hypovolemic state. That's why it could be interpreted as relative versus absolute. But the majority of the septic shocks come in with hypovolemia due to relative hypovolemia. And it doesn't matter that the volume is in the third space and the patient is edematous, you still have to give fluids to the patient to bring it into the vascular.
That's a contradiction because a lot of people don't.
It is. It is, but as soon as the patient wakes up, as soon as the patient stands up from the bed and start mobilizing the body with PT and OT or whatever, that fluid goes away. Okay? So, we talked about why they go into cardiovascular depression, any shock. We talked about why they go into ARDS, cardiogenic versus non-cardiogenic type of pulmonary edema, and why they also create microthrombitis. Okay? So, again, in summary, what happens in septic shock is the actual endotoxin and exotoxins will create a major activation of the inflammatory cascade, producing massive vasodilation, redistribution of fluid. Every single shock, not necessarily septic shock, will have hypoxemia to the tissue, and therefore SVO2 decreased. We talked about the relative hypovolemia, and what are the consequences that can lead to that, like myocardial depression, for example. And bringing the patient with a normal cardiac output and leaving with a very, very decreased ejection fraction. So how will you treat septic shock? As I said, first of all, if you don't know the etiology, you're thinking about possible infectious process while you're investigating the source. You have to put the patient on fluids, right? Bolus of fluid, maintenance as calculated that you learned, broad spectrum antibiotic. Before you start the broad spectrum, you do cultures, right? And again, try to identify the source and treat appropriately. If the patient does not improve with fluid resuscitation, of course you're going to start vasopressor support. Which one is the best? And that's an answer for one of your exams. I don't know if it's mine, if it's excellent. Levofed. So norepinephrine is the first initial choice. Okay? First initial choice, not dopamine. Dopamine, you have to actually increase the dosages to be able to get the same sympathetic response. Okay, so I know that a lot of practitioners do it just because, oh, let me put the low dose for renal clearance. No, guideline does not even approve that anymore, even though there are many practitioners with old-fashioned way of working still, okay? So, if you do have a depressed ejection fraction, either chronically as underlying chronic condition, or because the sepsis itself or any type of blood shock depressed the EF, you can help the patient with dobutamine, ionophore, or primaphore, okay? And again, if it's necessary, of course, intubate the patient and ventilate the patient. We went through, remember, it's not 20 to 25. The new guideline is 30 mLs per kilo. 30 mLs per kilo, okay?
Professor, we have a question.
Yes.
With norepinephrine, that's the one that affects the heart rate.
Oh, no, the most. The most. The most. I know your question. I know your question. How come, Professor, how come I'm going to start the patient on Levofed, norepinephrine, if the heart rate is already high?
Because the heart rate is
While you're still treating the underlying condition.
Is it ejection fraction? Is it because
Well, first of all, no. No. While you're still treating the underlying condition, first of all, you're going to start titrating that Levofed down, okay? And the tachycardia will go away. It's like, okay, you tell me now that patient has an acute bronchospasm and patient is albuterol, right? But the patient's tachycardic. And that's okay. And that's okay. Unless you don't go over 150, keep giving the albuterol.
It's like
Because the bronchospasm itself giving you shortness of breath, tachypnea, anxiety will give you tachycardia. As you control the bronchospasm with the first leading medication, which is albuterol, no Sopanex, no levobuterol, that tachycardia, that tachypnea is gonna go away.
So if I fix the blood pressure, the heart rate will go down.
Yeah, no, that's a good
And the more you vasoconstrict, the more you increase your preload, the more you increase your cardiac output.
Unless
It's
resistant.
a debate, because we're like, oh no, Leo says the heart rate's high, then it goes for dopamine, like, no, but.
Unless your heart rate is, I mean, you're not gonna put the patient on Levofed if the heart rate is 150 or more, but if it's 110, that's
That's
fine.
what I'm saying, like 100%.
120 is fine. We're just afraid, and we treat with norepinephrine, I mean, eosinephrine.
But dopamine also makes it this way.
High, and gives you a lot of arrhythmias. And the patient's already with high risk of cardiac arrhythmias to begin with, right?
Yes,
In any state of shock. So that's another reason why you should choose dopamine. Now, if a patient is immunocompromised, I don't know if you remember that I told you once through when we were treating infection, like general infections. Remember that, yes, you start with broad-spectrum antibiotics, but if you see that the patient continues to be febrile and you're giving the appropriate antibiotic based on sensitivity by the cultures, and the patient is not improving sepsis-wise, that might be the reason why, because the patient is immunocompromised, they're not covering antifungal. And I don't know if you have seen that they start giving patients antifungal and even antiviral just to cover everything just in case. But that's when the patient is not getting better, or you know already from the beginning that the patient is immunocompromised. Which of the following hemodynamics variables would most likely be assessed in a patient with shock? If I tell you, I actually attached another.
There's another one with the right band.
Right. I attached this like a pocket of the normal values, okay? That you don't need them all, but if we go over it, for example, of course, you know that 90 to 100, right, is the normal saturation, right? Now, mixed venous saturation, this is the one that I mentioned, that all the shock, all of them, hypovolemic, cardiogenic, obstructive, and distributive, which includes sepsis, anaphylactic, remember? Okay, and neurogenic. All of them, what's the end problem? Tissue hypoperfusion. So that means that the amount of oxygen in the tissue is low. SVO2. And the normal is 60 to 80%. So you should see individual Leo, which you measure that in a central venous catheter, okay? You could see these values, okay? The central venous saturations, I'm not gonna, go over that because basically what we look in the catheter is that one. Blood pressure, you can actually measure the monitor. If you want an accurate blood pressure, do a radial or femoral line, arterial line, to be able to measure it. MAP, okay, you know that yes, in the monitor is the one in parentheses, but if you want to really know how to calculate it, you basically would do your systolic blood pressure plus 2 times diastolic blood pressure divided by 3, okay? And you know that to be able to have a normal autoregulatory state, and that applies also for the CVB, cerebral perfusion pressure, right? You should have a perfusion of no less than 70 because otherwise you will go in vasoconstriction, no more than 105 because otherwise you go in vasodilatory state, and that affects not only the perfusion of the tissue, including cerebral perfusion pressure in the brain, okay? So MAP is there. Another parameter that you're gonna see mostly on echo, but central venous pressure, okay? And it's coming to your Barclay exam as well. The normal is 2 to 6. So when you have less than 2, patient is dehydrated. When you have more than 6, patient is what? Fluid overload. But what did I explain in cardiogenic? The backup of fluid is read by the catheter as hypovolemic when the patient is actually Dehydrated. I mean, dehydrated, but it's not pumping fluid effectively, right? This, you're gonna see in echocardiogram, or if you actually put a pulmonary artery catheter on a patient, you're able to measure the right ventricular pressure. Otherwise, you're gonna see it in an echocardiogram as well. Again, the pulmonary artery pressure, mean or occlusion pressure, you're gonna see either in a pulmonary artery catheter or in an echocardiogram. So, at least for me right now, I'm gonna ask you CVP, right? Because that's our goal. Cardiac output, you know that is 4 to 8, and half of that is your index. Stroke volume, remember that the stroke volume is still more. If you remember the equation, if you remember that cardiac output is equal heart rate times stroke volume, and the stroke volume is preload, afterload, and contractility. You remember that from Paco? Okay. Yeah. So the stroke volume is 60 to 100. Okay. So far, basically what you're asked all the time is either the values, decrease or increase, just arrows, increase or decrease, or, for example, how much is going to be the CVP, which I saw the other day on Baptist students graduating on the Barclay exam. How much is going to be the CVP on a patient with cardiogenic shock? And for example, they give you 1, they give you 5, they give you 15, and you gotta choose 15, right? The same as how much is gonna be your SVR on a patient with septic shock, and they give you, for example, like 400 versus 1800, so you would have to choose 400. So it's either or, okay? So stroke volume, which again, your cardiac output, remember in hypovolemic, we're gonna go through the arrows right now. Cardiac output is decreased in hypovolemic, cardiac index is decreased in hypovolemic, preload is decreased in hypovolemic, SVR is increased, right? If the cardiac output and index are decreased, the stroke volume will be decreased, right? So we're gonna go through all that. And remember, the other value that I want you to know is systemic vascular resistance, okay? Now remember, if you have vasoconstriction, you have elevated SVR. If you have vasodilation, you have decreased SVR, okay? So I added this for your own good. All right? So tell me now then, what parameter you're gonna see in hypovolemic shock? You're gonna be tachycardic. So for example, let's start ruling out. Okay, let's start ruling out. This one cannot be at all. Fuera. Out. Because you're tachycardic. So you have only those 3 choices. Now, SVR, if I tell you again, that is 800 to 1800, right? I'm sorry, 1200, I'm sorry. It has to be greater than 1200. So you have this and that. So at least I have this 2 out already, right? So keep analyzing. My cardiac output normal is 4 to 8, and you know that in hypovolemic shock, the cardiac output is low, so it has to be 2.
The first one.
Okay, so we already talked about which vasopressor support to choose, and here, first choice, not epinephrine. You need inotropic support, you can put dobutamine on it. Now remember, again, we finished hypovolemic. Cardiogenic shock, remember, the problem is not volume. The problem is pump as a failure. Doesn't matter if it's related to cardiomyopathy, valvulopathy, cardiac arrhythmias, heart failure, any type, or any type of obstructive shock. PE, cardiac tamponade, or tension pneumothorax. So if you look here, for example, looking at any type of cardiogenic shock, what's going to happen? Of course, you're going to have decreased cardiac output, decreased stroke volume, giving you hypotension, right? Pump as a failure. Decreased coronary perfusion, that's going to lead to ischemia. Ischemia, hypoxemia to the tissue, right? And of course, progressive heart failure and death. Now, this is the compensatory state. All right? Remember, in the compensatory state, red is late stages. This stage is what I have is hypotension, and even though the heart as a pump is failing, my sympathetic response is not affected. So I will still have tachycardia, okay? Trying to autoregulate until the point that later stages, but I'm not gonna ask you those later stages because it's not the norm. Patient, of course, will go into bradycardia, vasodilatory state, and death as well, okay? So it seems overwhelming, but it's not. You have a cardiac arrhythmia, either tachyarrhythmia or bradyarrhythmia, doesn't matter. If you come slow to me as the blood supply, you're not going to perfuse as well as if I am doing this and I'm not allowing the heart to receive the proper amount of blood and therefore not getting a proper cardiac output. But either or, it doesn't matter. What's going to happen is that either if you have severe bradycardia or severe tachycardia, again, severe tachycardia, as I told you, is going to decrease the diastolic timing to receive the blood supply. Therefore, you're not allowing the ventricles to feel properly. Therefore, the cardiac output is going to be compromised, low. Okay? So, what happens is that, again, if I don't have a proper cardiac output, what's going to happen in my right atrium, my right ventricle? That means my venous pressure is going to be building up blood, backing up, right? Building up blood in the back. And when you put the patient into any catheter, pulmonary artery catheter to measure wedge, or you put a central venous catheter and you measure CVP, what's going to happen is, again, since you have jugular vein distended and pressure, you put a catheter there and interprets that as either increased pulmonary wedge pressure or increased CVP. You cannot forget that, because the difference between hypovolemic and cardiogenic is the increased CVP and increased wedge if you have a pulmonary artery catheter, okay? So you know the rest, that edema and all that, okay? If it's heart failure. If it's related to, again, valvulopathies, it doesn't matter. I mean, you're expecting to have worsening cardiac output if you have, for example, aortic stenosis or aortic regurg, right? But if you either have a hypertrophic cardiomyopathy, remember that hypertrophic cardiomyopathy is asymmetry of the septum, producing left ventricular hypertrophy and closure of the aortic valve. So they die when they start running because of the asymmetric septum, even though it could happen in elderly. I've seen it in elderly, but it's highly congenital. Okay? So either or, having aortic stenosis or aortic regurg is going to decrease your cardiac output, decrease your stroke volume, and the same thing happens. Okay? And the rest here you already know. I mean, if you have, for example, decreased cardiac output and decreased stroke volume, of course, the vasculature of the brain is not going to be as perfused, and the patient might come in with the ultramental status, but that happens when it's shock. It's not specific for cardiogenic shock, okay? So, major complications that can have a patient with any type of shock, any arrhythmia, PE, tachyarrhythmia, ventricular tachycardia, with or without pulse, right? Fibrillation, etc. If you have a myocardial infarction as well, you have an MI, or you have heart failure, you have decreased contractility of the ventricles, and that affects the cardiac output. Is it the same? So it doesn't matter the etiology. What leads you to heart failure, you're going to have decreased cardiac output, decreased stroke volume, decreased cardiac index, but increased central venous return. And because your sympathetic response is not affected, you're still going to have tachycardia and vasoconstriction, therefore your SVR is increased. And because in all the shocks you would have tissue hypoxygenemia or tissue hypoxia, your SpO2 will be decreased. Okay? So you have it all there. We already went through that. So signs and symptoms really depend. I mean, if you come in with tachyarrhythmias or bradyarrhythmias, you're not gonna have reps, right? So it really depends what the underlying problem. Okay, if it's an MI, if it's a valvulopathy, if it's a cardiac arrhythmia, if it's a CHF, if it's a tamponade, what will you see in tamponade? Hypotension, tachycardia, what else? Widening pulse pressure, what else? Distant heart sounds, right? Okay. So it really depends. Now, as I said, any type of shock that is compromising cardiac function, try to avoid sedative in the intubation process or after intubation. That could depress even more the cardiac myocytes, such as propofol. Don't give up butirates unless the patient's in seizures, right? Intubate with the least myocyte depression, which is etomidate. And you can, of course, paralyze the patient with succinylcholine, right? After that, I would do, for example, fentanyl. If you want to keep the patient awake, which I don't recommend, if the patient is in shock, try to decrease the metabolic demand and the work of breathing. So knock the patient out with fentanyl, okay? Or rock.
We have we were talking about the potassium, which is
Yes.
right to give the rocks. I don't like you giving substance, the same thing.
Right.
I know potassium, I would give the rock.
Right, exactly, and even more these patients that are in any type of shock, you know, the potassium goes out, so
So it's
that's the reason why we use rock the most. Again, as I said, you could either use any inotrope such as dobutamine, amridone, which is inocore, or milridone, which is primacore. Okay, I'm not going to ask you dosage. Remember, do not give fluids to cardiogenic shock. Inotropic support. What else do we have? I mean, you can, for example, if the patient is or triple vessel disease, I don't know if you have seen patients going to CABG and then coming back to balloon pump, or patient going to cardiac cath and coming back with balloon pump because the inotropes are not as effective in that case, right? So as a transition. So basically to increase the cardiac output with the intra-aortic balloon pump. Okay? In case you don't know, the intra-aortic balloon pump, the way the coronaries get perfused is diastole. And if you put a balloon in the descending aorta, when the aorta is trying to flush out blood in systole, there is a remaining amount of blood here that actually regurgitates back in diastole, so the coronaries get perfused that way. Okay? So again, what else can you do? I mean, the mainstay, again, depending on the underlying condition. You're not gonna put a patient on heparin drip if the underlying problem for cardiogenic shock is cardiac arrhythmias. Treat the cardiac arrhythmia, and the cardiogenic shock will go away. But if the case is an acute coronary syndrome, you go through the protocol of acute coronary syndrome, like aspirin or double antiplatelet therapy with Brilinta or Plavix, right? You give a loading dose and then you continue. You put the patient on heparin drip. You bring the patient to the cardiac cath, right? Unless you don't have a facility that is has a cath available, then if it's a ST7 elevation myocardial infarction, then you might give thrombolytics, okay? Another cause of cardiogenic shock we already went through, right? You know, PE, pulmonary embolism. So how do you treat pulmonary embolism? Remember that to the extent to give you cardiogenic shock, it must be massive. So if it's massive, thrombectomy or thrombolytics, unless it's contraindicated. Otherwise, if it's contraindicated, you put the patient in heparin drip and you transition or you bridge the same way you bridge in any PE and following up that echocardiogram, okay? Now, remember, this we use in clinical practice as a temporary measure, okay? But the main treatment for PE, you know it already, right? Now, this is a catheter for thrombectomy that we use, okay? Which one? So close. Anaphylactic. What's the problem with anaphylactic? Well, any type of allergen that the patient is exposed, mastocyte degranulate, histamine is released, producing a massive vasodilatory response. Histamine produces, and all the cytokines produces vasodilation, bronchoconstriction, okay, and as well capillary leakage and edema. Remember, this is hypersensitive reaction type 1, release of eosinophils and IgE. Right? So you have here, for example, the actual injury, right? You have either in sepsis or in anaphylactic, you have an inflammatory reaction. Inflammatory cascade is activated, triggered by mastocyte degranulation and histamine release. As I said, you have vasodilation, capillary permeability, okay? And that vasodilation and maldistribution, as I told you, it gives you a relative hypovolemia and hypotension, and therefore tissue hypoperfusion. Treatment. Well, of course, you have to actually EpiPen or epinephrine, right? You have two types of dosages. The one that we give in the CPR is 1 in 100. The one for anaphylactic shock is 1 in 10,000, okay? So you give the epinephrine, and also we actually have the same preparation that you have for a patient that is going to, for example, CT angiogram that is allergic to iodine. You can also follow. You give the patient the fluids, you give the patient Pepsid, you put the patient on Benadryl, and you give the patient Solumedrol, okay? So that's an actual package that we have as a protocol, all right? Why Pepsid?
Because it's histamine blocker.
It's antihistamine. Remember that you have two types of H receptors, H1 and H2. How do you antagonize H1? Epinephrine, right? Or Benadryl. How do you antagonize H2? H2 blockers, Pepsid. That's the only rationale, okay? IV steroids to depress the immune response to that allergen, and fluids, that's it. So, you know how a patient with an anaphylactic shock comes into you, right? Stridors, wheezing. So, I already went through that. What else can you give, which we don't give anymore? This is a highly cytochrome P450 medication that is like no anymore. But in other countries, they keep using it. So Pepsid, Benadryl, you could choose any type of steroid, but in clinical practice, we either use dexamethasone, which is Decadron, or methylprednisolone, which is Solumedrol. Okay?
What's the difference between those two?
Short acting and long acting. That's it. Okay? And of course, secure the airway if it's necessary, right? Another shock, neurogenic shock. What's happening to this one? Remember, you have distributed shock, distributed septic, which we already covered, anaphylactic, and neurogenic, okay? So the problem with this one is that you had a stroke, a spinal cord injury, traumatic brain injury, or any neuromuscular disease that can affect the spinal cord response to sympathetic stimulation. So the problem is that there's sympathetic loss, okay? And parasympathetic nervous system prevails. And do you remember that parasympathetic will give you bradycardia instead of tachycardia? all right? So the patients would have, yes, decreased venous return CVP preload. Patients, yes, would have decreased stroke volume and cardiac output and cardiac index, but what about the SVR? The same as septic and anaphylactic. Low, because of massive vasodilation. Even though anaphylactic and septic will still give you tachycardia, this one will give you bradycardia. So, professor, if septic and anaphylactic give you tachycardia, how come my SVR is low? Because the amount of cytokines that are released actually either balance out or they actually prevail more than the adrenaline, noradrenaline, and noradrenaline. So either you would see it in the arrows, is either normal or low. Okay? So for a matter of difference, we have to put that is SVR low. Okay? Now, I forgot to tell you something in sepsis that you would see. If you go back and you review infectious processes that we covered in 667, sepsis has two phases as well. Hyperdynamic sepsis and hypodynamic sepsis. What do you think is going to be initial? Hyper or hypo?
Hyper.
Or you try to do everything possible in initial stages, right? And then when you're tired, you go hypo, right? Because unfortunately, what do you do when you have fever? You go straight to the hospital? No. You try to do everything like go over the counter, buy this and that. You might get prescription from your neighbor, viral medication from your neighbor, or leftover, right? That you have from your child or from home, don't you?
Yeah.
Everybody does that. If you can self-prescribe like me, no, I don't prescribe for myself because I can't. I prescribe to my husband or my son, and I get it. So if you do that, what stage do you think you're gonna come to the hospital? Later stages. And they listen to me. Yes, sepsis, septic shock has two phases, and you would see it in the arrows in the table that I will show you right now. Hyperdynamic and hypodynamic. So you would see that in the hyperdynamic, the cardiac output increases instead of decreases. But I'm not going to ask you that phase because the most common phase is hypodynamic. You will see the difference. Because you just said that it's decreased and now it's increasing the table. I had to tell you that so you could be aware of it.
No, because I'm thinking if you're tacky, it's about tacky how high you go, eventually your cardiac output is going to decrease regardless.
Regardless, but again, at the initial stages, what do you try to do? Vasoconstrict to increase. So in the very, very initial stages, unless you're obsessive compulsive, that every time you have a little bit of fever, you go to the hospital, you might catch that phase. But exist. The majority of the patients come in already in the hypodynamic phase. Okay? So how do you treat neurogenic shock? Well, again, of course, if it's a traumatic brain injury, you have to, again, treat the underlying problem. If it's a stroke, you treat the underlying problem. But besides treating the underlying problem, how do you put the patient back? First line, okay? But you could do beta agonist or alpha agonist as well. Now, these are the causes that can give you neurogenic shock. And of course, it's all brain-related or spine conditions. Okay? So, what else can you do? You could do norepinephrine, neosynephrine, you could do ephedrine, like vasopressor support if the atropine does not improve the bradycardia itself, or you could even put the patient on a temporary pacer or intravenous pacer, but until the patient doesn't leave the spinal shock phase, it's not going to go back to normal heart rate wise. So this is not a patient that's going to gain a permanent pacemaker. You have to treat the underlying problem, okay? So we went through that. Question, what's the difference between anaphylactic and neurogenic shock in hemodynamics?
The reason why there is
Ah, well done. Yeah, again, I feel like to show you're gonna have an increase of
The only difference is the heart rate.
Exactly. Anaphylactic is tachycardic and neurogenic is bradycardic. That was a question since battle. Okay? We went through obstructive shock already, right? I explained you the PE, I explained you the cardiac tamponade, and I explained you the tension pneumothorax. This is what you need to know the most. Let's start. Oh God. Well, let's start with the most common. Let's start with the most common, which is hypovolemic. Okay? The second. Let's go through the second. All right? So in the second, hypovolemic shock. First of all, hypotension, right? Since your sympathetic response is okay, you have tachycardia, right? So already it's high. The more tachycardia, you narrow the pulse pressure, so it's going to be high. This is elevated systemic vascular resistance because the epinephrine, norepinephrine, and dopamine produces vasoconstriction, right? So that's going to be more than 1200. The same as peripheral vascular resistance. So if you don't have enough fluid to bring in, how's going to be your preload? Which is CVP? Low. Yes or no? Okay. How's going to be your wedge pressure? Low. How's going to be your cardiac output? Low. If I ask you index, low. If I ask you stroke volume, low. How's going to be your tissue perfusion? Low. Of course. Do you understand?
Yes.
Next, cardiogenic. Cardiogenic is the pump failure. So therefore, no volume problem, right? So pump failure. If I have a pump failure, I have a hypotension, yes?
Yeah.
My sympathetic response is okay, so I have tachycardia, increased heart rate, therefore I have a narrow pulse pressure. Same thing so far, yes? So, because I have tachycardia due to vasoconstriction, because I don't have any problem in sympathetic response, my systemic vascular resistance is elevated, right? The same as peripheral. Now, again, what is the difference between hypovolemic and cardiogenic? Because there's a backup of volume due to pump failure or obstructive shock, my reading is interpreting that I have hypervolemia just due to the backup of fluid here in my neck. Okay? So that's the reason why my CVP preload is high. So you put an asterisk there because that's what difference says between hypovolemic and cardiogenic. And if your CVP is high, that means if I ask you differently, preload is high. And if I ask you different, your wedge pressure is high. Okay? And of course, since your pump is failing, you're going to have a decreased cardiac output and therefore your tissue will be hypoperfused. Do you understand? Yes. Good. Distributive shock. Remember that distributive shock are three types, right? You have neurogenic, anaphylactic, and septic. All right? Remember, massive vasodilation. Massive vasodilation, even though you still have sympathetic response, okay? Except neurogenic, right? So let's start with the most common, septic shock, all right? Since you have hypotension due to septic shock, your sympathetic response is okay, right? So you have increased heart rate, all right? So hypotension, tachycardia. Now why my pulse pressure is low instead of high? Because even though my autoregulatory response with my sympathetic nervous system is okay, I have a massive vasodilation that is putting apart systolic and diastolic. All right? Since I have a massive vasodilation, my distributive shock will have decreased SVR. All of them.
because it's vasovagal.
Exactly. All right? Forget about the peripheral vascular resistance because you have central vasodilation and peripheral vasoconstriction because your sympathetic nervous system is okay, but leave it like that. All right? Now, central venous pressure. Of course, if you have a massive vasodilatory response and you have redistribution of fluid to the third space, that's going to be your vascular space, depleted. So therefore, your preload is low, right? And if you're expecting, listen, you're expecting if your preload is low, your cardiac output is low, and your cardiac index is low, right? Yes, it's true, but depending on the phase. If it's hyperdynamic or hypodynamic. And that's the reason you have these two arrows right here, okay? So if you have these two arrows, it's increased in hyperdynamic initial phases, and it's decreased in the most common, which is the hypodynamic presentation. That's the reason you have chup, chup, chup. Okay? And again, even though all the shocks have tissue hyperperfusion, in the initial stages of hyperdynamic, your tissue perfusion is trying to compensate until you fail and go into hyperdynamic shock, and of course, you're gonna have tissue hyperperfusion. Now, what do you think I will ask you? The hypodynamic phase, meaning that you have a decreased cardiac output and you have a decreased SpO2. So what is the difference, guys, between hypovolemic and distributed shock? What is the difference between hypovolemic and distributed shocks? SVR only. All right? Anaphylactic. Anaphylactic. An anaphylactic shock, all the shock must be in hypotension. Because in an anaphylactic shock, your still sympathetic response is okay. You have tachycardia, right? And the pulse pressure is decreased. Why? Because of massive vasodilation. Because of massive vasodilation, my SVR in all distributed shocks are decreased. All right? Therefore, in all of them, forget about this arrow here, because this is septic hyperdynamic, in all the distributed shock, your cardiac output and index and stroke volumes are low. And therefore, your SpO2 is also low. Do you understand? Good. Now, the difference with neurogenic shock is that, yes, you're hypotensive, but you're bradycardic. The rest is the same with any type of distributed shock. Obstructive behavior, cardiogenic. All right? You need to know that table. By heart. By heart. I'm going to let you use it, but you're not going to be able to use it for Barclay. Nothing will be able to be used by Barclay. Nothing is empty-handed, only computer. You're going to be having your exam with family nurse practitioners and professors for family nurse practitioners. I would not allow you to use anything because they can't use anything.
You mean the exit?
It's a mixture of, it's actually an auditorium that everybody's there. And there's like 5 professors.
I'm gonna be classified with
It's cardiogenic.
But the FDR is
Why is it a little different? Okay, let's start. Obstructive. In obstructive shock, you're hypotensive. But if you have a PE, you're anxious. You have tachycardia, right? If you have a tension pneumothorax, I bet you're going to be tachycardia. If you have a tamponade as well, right? So the sympathetic response is not affected. Right? And now, the pulse pressure, why is the pulse pressure different in someone? Guys, if you have a PE or tension pneumothorax, your pulse pressure is going to be narrow. But if you have a tamponade, which is you have an interface of fluid this much, one of the major characteristics of cardiac tamponade is what, it's actually one of the triads. Widening of the Beck's triad, while the widening pulse pressure is one of the major characteristics, okay? So it really depends which one, okay? So in obstructive shock, in reality, the SVR is not decreased.
Oh, why?
It's
We-
not.
Like, if you had an obstruction, you're increasing that, you have like constriction, you're gonna have an increased pressure.
Exactly.
So you're gonna have a high SVR.
Correct. I mean,
It's low then.
yeah, it's low, but it's not. This is not true. Again, unless, I mean, unless it's only a tamponade, but all the obstructive shock, if you're pushing off the mediastinum,
Increasing the pressure.
you're decreasing cardiac output, you're increasing preload, you're increasing pressure in the cavities, therefore your pulse pressure has to be high.
So it's out.
It is high. Now, why the CDP is high? Why the wedge pressure is high? Because it's exactly the same presentation of cardiogenic. You have a pushing of the mediastinum due to PE. You have, due to high pressure in the pulmonary, right? You have pushing of the mediastinum due to tension pneumothorax, or you have a pressure in the periphery due to cardiac tamponade. What's gonna happen to the CVP? That blood backs off. It doesn't enter the atrium. So therefore, again, jugular vein distension, when you put a catheter, it's gonna be intraparastyle, okay? And wedge pressure, again, the majority is high. And cardiac output, of course, is low, cardiac index is low, and cardiac and stroke volume is low. And of course, in any type of shock, tissue hyperperfusion is low. Do you remember when I went in the explanation of tension pneumothorax, okay, that I told you that in tension pneumothorax is
You're talking about the wedge pressure?
yes. Remember that I told you that in tension pneumothorax, when you squeeze the heart to this side, okay, you're not allowing enough blood to come into the right atrium, right? And again, yes, that affects cardiac output. And you, again, I told you, you might believe that that also affects the preload. And yes, when the patient's trying again to compensate, it happens. But as the blood backs off, increases the wedge pressure and increases the CVP. So the variability is related to the stage. But any obstructive shock, common presentation again is you have, because of the obstruction itself, you have decreased cardiac output, you have hypotension, you have tachycardia. Because of the backup of flow and increased JVD, you have an increased CVP, you have an increased wedge pressure, okay? And of course your tissue hyperperfusion will be high. Now, how's gonna be your SVR? I cannot tell you the reason why this website has here low, because every type of obstructive shock in cardiogenic, this is a type of cardiogenic that was actually in the past classified as cardiogenic. So the sympathetic response is never affected in this type of patients. And there's always vasoconstriction. There's no vasodilation at all. So I cannot explain why that website has
But we keep it alive.
high. Okay? So again, these are the stages of shock that, again, I mean, makes sense that in any type of shock, you have, again, switching from aerobic to anaerobic. We're repeating ourselves. Elevated lactic acid, and clinical signs and symptoms that pallor, etc. The compensatory states that we already went over, right? So you can read that because it's the entire pathophysiology that we went over. Major complications associated, you have a lot of electrolyte imbalance, you have hyponatremia, hyperkalemia, you have hypocalcemia, you have metabolic acidosis. Initial stages, you have respiratory alkalosis to try to compensate by pulmonary respiration. When you get tired, you have a mixed acidosis, right? And you go into respiratory failure. You have edema due to capillary permeability. You can go into any type of tachycardia, arrhythmias, hypotension, powder, coolant damage, skin, etc., up to the point of irreversible organ damage and death. right? So this is the same, the entire compensatory mechanisms, okay?
So for the test next week, this is included or not?
Yes. All right, you have a summary here of the most common values asked. Okay?
Professor,
Yes.
look the SBR over there.
Okay. So,
It's good.
exactly. So let's come here. Cardiogenic, again, as I said, is heart failure. Even though it's not necessarily only heart failure, but basically leads all of them to it. Pump failure. Decreasing cardiac output, decreasing cardiac index, right? Decreasing stroke volume, very similar values, right? Therefore, because the sympathetic response is not affected, and you have tachycardia and vasoconstriction, you have increased SVR. In obstructive shock, the heart fails as a pump as well, because it's either squeezing it or not allowing blood come in due to cardiac tamponade, etc., or because of high pulmonary pressure, it's pushing against the right ventricle, decreased cardiac output, decreased cardiac index, decreased stroke volume. Remember here, in cardiogenic shock, we have an unobstructed, what do we have? Increased CVP, which is the same thing as increased preload, same thing as increased wedge pressure. And we have the compensatory mechanisms. In hypovolemic shock, we don't have preload, so decreased CVP, decreased cardiac output, decreased cardiac index, decreased stroke volume. My sympathetic response is not affected as well, so I have an increased SVR because I have vasoconstriction. And in all distributed shock, anaphylactic, neurogenic, and septic, I have well, listen to me. Remember, if it's hyperdynamic shock, I have an increased cardiac output. Otherwise, in hypodynamic and the rest of the shocks, I have decreased cardiac output. Don't tell me, Professor, that table says increase. And that's the reason why I answer that. And why decrease SVR in all distribution shock? Massive vasodilation. Any questions? We actually went over the hemodynamics already, so there's no need to open up the 20 slides of hemodynamics. It's the same thing. And you have the actual normal values. The rest is only the guidelines. All the papers that we have in the PowerPoint is the guideline, but we already have explained it extensively. Any question? So yeah, I promise that I will send you the quiz.
So, hypernatremia. Oh God.
Okay, hypernatremia.
Hypernatremia.
So the main bulk